Thank you very much for the invitation. I'm very excited to share with you my experience and also the future developments for our patients. I don't have any conflict of interest. If we are speaking about history, we should talk about Gustav Kilian, because we are here because he wants to remove foreign bodies, even if it was ear, nose, throat doctors. He wants to go far away and to remove them, and he developed the bronchoscopy. I steal this photo for Professor Gasparini from yesterday's topic, because we can see in here that rigid bronchoscopy was developed in 1897, but 100 years after, the stents are coming. All starts with a Montgomery tube. Everybody knows it. And extendable metal stents, the surgeons are developed then. You can see it now. And the GI doctors, Gian Torino stents in here. You can see it at the right. Like my colleague said, the metallic stents have some complications. That's why at the beginning they were using it, but nowadays we know better. You can see in here some complications after putting metal stents. They can destroy the trachea, the mucosis. They advance and they make it, like Melvin said, the covered stent, metal stent. They try to cover it with combined metal and silicone. After this, the bioabsorbable stents offer a temporary solution. They are at the beginning for the pediatric patients, but afterward, for the adults also we are using it. And nowadays also with 3D print stents. My colleagues also showed these stents to you, and in my opinion, self-extended stents, I'm using it for the malignant situation. They are easy to install. When you have some bleedings, you don't see very well, you can put it quite easily. They are most commonly can expand 2 feet the diameter that you need. But they can migrate, they can cause damage. And if you leave them a couple of months, they are difficult to remove. The silicone stents are custom cuts. This is the benefits. You can cut it in your way, and what do you need? It's a long-term tolerance. They are flexible. And nowadays, the biodegradable stents, drug-eluting stents, radioactive stents, and the 3D stents. This is how we are putting a silicone stent for the tracheal stenosis. For the self-extended stent, you already saw with Melvin, I think. They are already in the device, and you are only put them in the bronchial where the stenosis and where you're needed. And I told you, they can expand in the bronchial. This is collapsus. You can see a collapse at the left, now at the right, and you can see it after in the trachea also. And we decided to put a silicone stent for tracheobronchial malacia. You can view in here. I put a lot of videos because yesterday everybody told me, how are you putting the stent? What is your... Did you see that Melvin is putting in his way with the balloon? We are putting with the bronchoscope. You can use everything to open up your stent. The forceps you can see in here, and the bronchoscope also. This is the part of the trachea, and after you will see the main bronchial also. You would see that the tracheobronchial malacy, you are dilated, but after the bronchial will, the stenosis will come back. This is a stent for a fistula. You know, not every time you can put a stent because there is tissue is very fragilized, and with the silicone stent you can increase the fistula. That's why you have to be careful. But you can see in here the tracheal fistula. You can see that the stent is a little bit far away when we deployed it. And now with the forceps, we'll put it in the trachea. And after we will open the stent to fit the measurements. If you don't achieve it, you can put it with the forceps, you can open it. And after a while, this is the results. For the after tuberculosis, I think Melvin already showed to you. We can put, we are using the silicone stent. Maybe some of you can use the extendable ones. In here we have post-intubation tracheal necrosis. This, I think, is an old case because nowadays we don't see it anymore. You know, with the pressure, with the balloon, make this necrosis. Nowadays we measure all the time the pressure in the balloon of the intubation tube, and we don't have anymore these cases. But you can have some damage of the trachea in an intubated case. You can see the cartilage, everything is damaged. And we need to cover this, like this, the secretization will do it behind the stent. Yes. Okay. This is for relapse polychondritis stent. I'm sorry. You can see everything is, and you can see a silicone stent. Put it. A T stent, a Diabolo stent, double-shaped. For the lung transplantation, sometimes we have some difficulty with only one, but Melvin also showed you, we can put a lot of stent. This is an Oki stent at the right, and at the left you also can put an Oki stent, but this time the angle wasn't matched. That's why we put extendable stent. This is the area of the action, and if we want for the little bronchial, we should think about a biodegradable stent also. This is my patient that after a surgery has a collapse. You can see it in here in the bronchial treatment. You can see a collapse of her lower left lobe that required daily bronchoscopic toilet for aspiration. And we decided to put a biodegradable stent for her. You can see it at the right. And you can see at the chest rate that the atelectasis at the lower left lobe after the stent was released. After total degradation, the initial collapse was reduced. There were no recurrent infections episodes, and since there, she was very good and didn't need another stent placement. This is the stent that we put for her. And you can see in here, because it's polyadenoid biodegradable polymer, for surgery and suture, and you can see in the picture the degradation of the stent. And what else? We can do some custom-made stent. You can see in here, after a lung transplantation, a patient loses his upper lobe, and we needed a stent, a trifurcate stent, and with a CT scan and bronchoscopy, we designed this stent and put it for him. These stents are unique anatomy for each patient. The design is very important. You should talk a lot with the industry. The quality of silicone is important. Effectiveness of the stent and the risk of complication and migration. This is another stent at the left, also custom made. They can reduce the number required of stent changing. They improve durability, doesn't deform because it's made for the patient. It's held well in place and doesn't migrate. At the present, there are two societies. In US, you can have visionary air solution with the stent. I don't have any experience. I work with anatomic modeling, and you can decide the stent that you want. These are the costs. I will not speak about the recommendation. Melvin already did it. And what is the future? We can have 3D stent bioresorbable. We can have a drug-eluting stent with anti-inflammatory, anti-prophylactic, antimicrobial, personal therapy delivering chemotherapy. The smart stents, they can measure airway pressure, airflow, or other physiological parameters. And some other stent would respond to changes in the airway environment, such as temperature or pH. We have a lot of choice for our patients. We should think of your indication for your patient. You should think of design also, the quality, our expertise, a good collaboration, and don't forget, it's still a foreign body. Thank you very much. Nothing will be possible. You're doubted that I'm not alone. I have a team that I work with. And I would like to thank you very much to Preeti and Harry for inviting me. It was a great congress. And if you have any question, this is my email address. Don't hesitate.